Please welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic will bring a number of questions from you. You may type your questions in that box, and I want to let you know that we will address as many as we can in the time we have today. So to present today's topic, I welcome Dr. Ashutosh Nangia. Welcome, sir. Over to you.
Thank you and good evening, everyone. I am Dr. Ashutosh Nangia, Associate Professor, North DMC Medical College and Hindura Hospital, Delhi. Today, we will be talking about how CSOM continues to ruin our lives. Right. So, I'm using first time, so please bear with me. Right. So, why CSOM? See, as trainees, you must realize that CSOM is asked as a long case in the practical exam. Definitely. Secondly, in theory, and from the practical aspect, it is the bread and butter of an ENT surgeon. So today we will be talking about the management of unsafe CSOM. Just a brief recap of what actually is unsafe CSOM. CSOM, or chronic suppurative otitis media, by definition is a long-standing infection of the middle ear cleft. It is of two types, which you all know: tubertympanic, which is also called safe or mucosal type, and involves the antero-inferior part of the middle ear cleft. The complications are much lesser in this variety. In the other type, that is the atticoantral or the unsafe, also called squamosal, the posterior superior part of the middle ear cleft is involved, this part. And the chances of complications are more. That is why it is called unsafe. Okay, so the atticoantral or squamosal variety, about which we are going to be talking today, can be of two types. It can be inactive, in which there is a retraction pocket seen like this, or it may be active, in which there is a cholesteatoma seen like this. The active squamosal CSOM may also have other pathologies like osteitis and granulation tissue. The most common part of the middle ear that is affected is either the posterior superior quadrant of the pars tensa or the attic region, that is the pars flaccida. Okay, now the important thing to remember is that the middle ear cleft epithelium is different in different parts of the middle ear. The antero-inferior part has ciliated columnar epithelium. The cartilaginous eustachian tube area has pseudostratified ciliated columnar epithelium. The bony eustachian tube has ciliated columnar epithelium again with mucus glands. The posterior part of the middle ear has cuboidal epithelium, and the attic and mastoid region has non-ciliated squamous epithelium. So the important thing to remember here is that nowhere in the middle ear cleft will you find stratified keratinizing squamous epithelium, which is skin. So we just said the pathology, main pathology in squamous CSOM is cholesteatoma. Now, what is cholesteatoma? First of all, the name cholesteatoma is a misnomer. There are no cholesterol crystals in it, and it is not a tumor. It is basically skin in the wrong place. That is, presence of keratinizing squamous epithelium anywhere in the middle ear cleft is called cholesteatoma. It has two main parts. One is the matrix, which is formed of the stratified squamous epithelium, which is keratinizing, and the keratin debris, which accumulates within it. So the histologically correct name for this entity is a keratoma. When it is filled with
Dr.
keratin,
Ashutosh, can you use the laser pointer, please?
okay. Is this fine, sir?
Excellent, sir.
Thank you. Okay. So when this cholesteatoma is filled with keratin only, it is relatively dry. But once there is active bacterial infection, it starts producing a very, very foul smelling discharge. This discharge is so characteristically foul smelling that if you have smelt it once, you cannot forget it. In fact, sometimes what happens is the speculum that you have used to examine the ear, if you don't clean it, it will keep on smelling on your table and you'll keep wondering where this smell is coming from. The cholesteatoma incites bone resorption and leads to intratemporal as well as intracranial complications. This is a very important topic from your point of view, often asked in the theory exam, the theories of cholesteatoma formation. We're not going into the details right now because it is beyond the scope of this lecture, but you must know the names and the details of these theories. The main two accepted theories for acquired cholesteatoma are the Wittmach's theory, that is retraction pocket formation, which leads to a primary acquired cholesteatoma, and the Haberman's epithelial invasion theory, which leads to the secondary acquired cholesteatoma. Please read up in detail. Okay, now you must be wondering why we are going on talking about cholesteatoma. So the problem with cholesteatoma is that it has a tendency to spread. It expands along the path of least resistance and causes bone destruction. The inflammatory reaction activates the osteoclasts or the mononuclear cells, and they release some enzymes like collagenase, acid phosphatase, and proteolytic enzymes. It is this enzymatic action of these enzymes which leads to bone destruction and spread of the cholesteatoma. The earlier theory of pressure necrosis is not accepted now. Some other pathological features associated with unsafe CSOM are granulations and osteitis. What is granulation? You all know that it is basically a neoangiogenesis. The connective tissue and new blood vessels are formed as a reaction of the bony inflammation. The osteitis leads to formation of the granulation. So if you find granulation in the middle ear, you can rest assured that there is bony involvement. Okay, these granulations may be found filling the attic, the adductus, and the antrum, and sometimes they may present as a fleshy red polypus causing blood-stained ear discharge. Another important thing that we all must know is that due to this inflammatory process and bone eroding properties, the ossicular chain can also get damaged. The long and lenticular process of the incus is the first part of the ossicular chain to get damaged. Like you see here, this is the most delicate, most susceptible part. After this comes the stapes superstructure and then the handle of malleus, in this order. Whenever there is ossicular necrosis, the hearing loss will be more, which is understandable, right? Now, there is one entity that you must know, which is called cholesteatoma hearers. See, sometimes what happens is this cholesteatoma, while it is destroying the ossicular chain, will come to rest between the two parts of the ossicular chain. For example, between the incus and the stapes. Now, in such a case, what happens is this cholesteatoma will conduct the sound energy from the ossicular chain to the foot plate. Now, why is it important to know this? Can anyone tell me? Can anybody answer this? Why is it important
You may unmute and answer the
Would anybody like to volunteer?
Yes, Dr. Kartika.
Because the cholesterol it will bridge the gap between the bones to the amount of hearing loss. Like after the OT, if we remove that cholesterol, patient can appreciate the hearing loss more.
Excellent. So what happens is when you are operating, you will remove this cholesteatoma, right? So you have to give the patient a realistic expectation of hearing after the surgery. See, you will do an osteoplasty, right? But the results are dependent on many factors. So you must tell the patient that after the surgery, the patient may actually start hearing lesser than what he is already hearing, right? Because this cholestoma is acting as a pseudo conduction mechanism. When you remove this, the patient does not know what is the pathology in the ear. The patient knows that he does not hear. So you have to give them realistic expectations. And especially in these days, everybody is very vigilant and they are medico-legally very active. So you must save yourself pre-operatively by proper counseling. Okay, now coming to the management. See, whenever you are asked about the management of a case, management does not mean treatment. Management means it includes diagnosis as well as the treatment. The diagnosis will start right from the clinical, that is history and examination part, and the investigations. In this case, audiological, radiological, and the preoperative investigations, and then the treatment. So please don't jump onto the surgery right away. Management includes all of this. That is diagnosis, treatment, clinical investigations, and treatment conservative as well as surgical. Now coming to these one by one. First of all, the history. What will the patient come to you with? The patient usually presents to us with history of ear discharge, which is scanty, purulent, continuous, foul smelling, not associated with upper respiratory infection, and may be blood stained at times. So it is important to understand the characteristics of the discharge, because based on the history, you must be able to form a diagnosis whether you are dealing with a safe type of CSOM or an unsafe type of CSOM. And more importantly, when you're presenting the history, the long case in the exam, the examiner wants to hear this. So you must know these characteristics of the discharge. Okay, now the other common complaint that the patient presents to us is hearing loss, maybe due to the tympanic membrane perforation or due to the ossicular damage. The hearing loss in cases of CSOM is mostly conductive, but sensorineural hearing loss can also occur in long-standing CSOM because of absorption of toxins through the round window membrane. If the patient gives a history of any of these complaints, these must be treated as a danger signal, indicating an impending complication. What are these danger signals? Persistent earache, vertigo, persistent headache, facial paresis, or any signs of intracranial extension like fever, nausea, vomiting, irritability, neck rigidity, diplopia, or ataxia. Is that clear? Now, can anyone tell me which complications of CSOM are likely to present with vertigo? Any volunteers? You can unmute and speak if you want to. Okay, I'm getting a few answers. Yes, labyrinthitis definitely can present with vertigo. Anything else? Yes, labyrinthine fistula. Okay. Any intracranial complication that can also present with vertigo? Any particular abscess involving some very nice cerebellar abscess? So these two complications can lead to vertigo. Okay. What about diplopia? Can anyone tell me about diplopia? Why would a patient with CSOM complain of diplopia? Which particular complication? Very nice. Grady-Negro syndrome. Okay. Can you tell me what is Grady-Negro syndrome?
Ear retroorbital pain, sixth nerve palsy.
Very good. So persistent otorrhea associated with deep-seated retroorbital pain and lateral rectus palsy or sixth nerve palsy, seen in cases of petrositis. Very nice. Okay. Now, on examination, you might find a retraction pocket in the attic region like this, or in the posterior superior quadrant of the pars tensa. Now, another common question asked is the stages of retraction of the tympanic membrane. So it is for the pars tensa, it is divided into 4 stages. A stage 1 retraction is tympanic membrane, that is pars tensa, retracted but not touching the incus. Stage 2 is retracted up to the incus. Stage 3 is tympanic membrane touching the promontory but still mobile. Now up to this stage, stage 3, this retraction is reversible and this is also called atelectasis. Stage 4 is when the tympanic membrane progresses to adhere to the promontory, and then this is known as adhesive otitis media. Now, once the tympanic membrane gets adherent, it stops moving, then it starts to collect keratin debris. Very similarly, for the pars flaccida, stage 1 retraction is when the TM is retracted but not touching the neck of malleus. Stage 2 is when it is retracted and touching the neck of the malleus. Stage 3 is when there is minimal scutum erosion, and stage 4 is when there is extensive scutum erosion. Then, besides a retraction pocket, you may also find a perforation in the attic or in the posterior superior quadrant of the pars tensa. Now, something very important to remember, especially at your stage, is that a small attic perforation may at many times be hidden by crusts, debris or granulations in the attic area. This is called attic wax. And if this attic wax is present, you may miss what is behind the wax. So as a routine, if you find this picture, you must always clean this debris and see what is behind the tympanic membrane. Otherwise, you may miss a small attic perforation or even an attic cholesteatoma. And if in PG you miss it, it is HAW. Okay. You also may find pearly white flakes, that is indicative of cholesteatoma. So how do you judge whether the scutum is eroded or not? See, the scutum begins above the pars flaccida. Scutum is the lateral wall of the bony lateral wall of the attic. The lateral wall of attic is formed superiorly by the bone and inferiorly by the pars flaccida. If the pars flaccida starts to retract, then only it will start eroding the scutum. Okay, if the scutum starts getting eroded, then you will start seeing a, can you appreciate this? I forgot the name of the person who asked the question. Yes. So can you appreciate the handle of the head of Malleus is totally exposed in this region, in this picture? This is the area that you usually see when you do an otoscopy, right? This exposed area, this ossicular head assembly, you will see only when there is scutum erosion. Is that clear? Okay. Now, like in this area, you can see that the scutum has been destroyed and you see the attic area filled with cholesteatoma flakes. Okay, now we proceed to investigations. The first investigation, although it is technically an examination, it is grouped under investigations that you must do in a case of CSOM is EUM, that is examination under microscope. It is a very, very important and informative part of the investigation battery, and it helps to clear the debris, discharge, crust, etc., and to determine whether the disease is tubotympanic or atticoantral. Because see, you need to plan your surgery according to your findings, right? Then you can make out the extent of disease and the ossicular status to a better degree than you do by plain otoscopy. If there is active discharge, you may like to get a pus culture and sensitivity done for giving directed antibiotics. Okay, now one of the most important parts of the investigation is hearing assessment. There are two things which you must do for hearing assessment. One is the tuning fork test and second is the PTA. See, tuning fork test is one part of clinical examination which is often neglected. Many people nowadays are not very fond of doing tuning fork tests, although they can be very, very informative. And if given a choice between PTA and tuning fork tests are more reliable because you're doing it yourself. So please never forget to do tuning fork tests during your clinical assessment. Now, which tuning forks to use? See, tuning forks come in a wide range of frequencies, starting from 128 right up till 4096 Hertz. So, which ones would you like to use for hearing assessment? Any takers? Which all tuning forks would you like to use? Okay, very nice. 256, 512 and 1024. So whenever you are asked this question in the exam, please don't say only 512 because ideally you should be using all three, 256, 512 and 1024, because tuning fork tests are not only qualitative, they are semi-quantitative. So if you do the tuning fork assessment with all three forks, you are able to get an idea of the degree of hearing loss as well. But if given a choice of using only one tuning fork, then you should say 512. Now, can anyone tell me why? Why only 512 if only one is to be used? Why not 256 or why not 1024? Okay, best heard. Anyone else? Okay. Okay, low tone decay. Anything else? Right, so there are two reasons for this. That why. Okay, yes, I'm getting the answers. So why you should use 512 if you are given the option of using only one? Ideally, all three. If only one is to be used, 512. Why? Because one, it most closely resembles the normal or the usual range of speech frequencies. Most of the people that you interact with or you talk to will be speaking around this frequency, right? Secondly, yes, it is the audible frequencies. Secondly, a low frequency tuning fork has propensity to stimulate proprioception or bone vibration. And a very high frequency tuning fork has a tendency to decay quickly. So 256 will stimulate vibration and 1024 will decay faster. So if only one is to be used, then 512. Is that clear? Okay. Now PTA or pure tone audiometry of the pre-operative hearing level gives you a documented quantitative as well as qualitative assessment of the hearing level. One thing it helps you with is counseling and giving realistic expectation to the patient. See, the patient has come to you with two things: ear discharge and hearing loss. And that is all that he is bothered about. The rest, everything else is your headache. Okay. So if you know pre-operatively the type and degree of hearing loss, you can counsel the patient accordingly. Secondly, from a medical legal point of view, if the patient later on sues you or files a case against you, you have a documented evidence that this was what was before and this is what is now. So it is mandatory to get a PTA done. Right. Then we move on to the radiological investigations. Up till a few years back, an X-ray of the mastoid, lateral oblique view, that is Schuller's view, was a very popular investigation for all cases of CSOM. But with the advent of high quality, high resolution CT scans and its widespread availability, the need for getting an X-ray mastoid has gone down very much. So in today's in today's scenario, the one radiological investigation that you would do in a case of unsafe CSOM is HRCT temporal bone, because good quality HRCT temporal bone can give you a lot of information about all the structures that you are concerned with while operating. Whereas an X-ray mastoid gives you just the level of the dural plate, the sinus plate, and the pneumatization, and if there is any lytic lesion. So it does not give you much more information than that. Whereas on a CT scan, you can have detailed information about almost all the structures that are relevant to you. Now, when to get a CT scan done? Should you get it done in all cases? Any takers for this? Should you get a CT scan done in all cases? Yes, we are talking about unsafe type only. So if in the examination this is asked to you, ideally you should get a CT scan done in all cases of unsafe CSOM. That is ideally, but it is not mandatory. Is that clear? Ideally, yes, but not mandatory. But there are certain definite indications in which it is mandatory for you to get a CT scan done. Okay. See, a CT scan is not without its own dismerits. Okay. It costs a lot. A CT scan in a private setup today costs anywhere around 4,500 to 5,000 rupees. If the patient is not able to afford that, then you cannot help it, right? Or if the patient has already had previous CT scans, because it leads to radiation exposure also. So there are limitations. But in cases where you are suspecting an impending complication, or there is evidence of an already set in complication, you must get a CT scan done. That is first. Then, if the patient has an only hearing ear with unsafe, yes, whether it is intracranial or intratemporal complication, you must get a CT scan done. And only hearing ear, a revision surgery, very important, especially if it has been done at some other center and you do not have the operative notes. It is mandatory to get a CT scan done. Surprisingly, if you are planning not to operate, if you are planning to keep the patient on conservative management, suppose the patient is unfit for surgery or refuses surgery or does not have money or for whatever reason, then you must have an idea of how deep the disease is, or is the patient likely to end up with a complication soon. You must get a CT scan done. Extremes of age, very young or very old patients. Before operating, you should get a CT scan done. Yes, if you are suspecting an anatomical, if you see an anatomical malformation or a variation on you're suspecting that, suppose the external ear is deformed or you see any congenital malformation, then you must get a CT scan done before you operate the patient. Is that clear? Okay, now coming to the treatment part. First, we come to conservative treatment. See, to be honest, unsafe CSOM does not have any conservative treatment. It is only a stopgap measure till you can operate, or just to be able to maintain the patient without surgery. It has to be done in properly selected cases, and the patient should be ready for a regular follow-up. This is mandatory. If you are keeping the patient on conservative treatment, the patient has to follow up with you regularly. Ideally, it should be done only in cases with a minimal pathology, which is amenable to suction clearance, or in elderly patients, or in patients who are otherwise unfit or refuse surgery. Okay, suppose there's a patient with a malignancy with disseminated mets or things like that, then there's no point in operating. So you just keep on patient on conservative treatment. The mainstay of treatment in unsafe CSOM is surgical intervention. The aims of the surgery are three in this order. First is to make the ear safe. Second is to make the ear dry. And third is to preserve or reconstruct the hearing. So these three aims of ear surgery have to be kept in mind and achieved in this order. Also, it is very important to explain to the patient that this is what you are going to try, because the patient, unlike you, does not understand that unsafe disease is likely to end up with complications, and it is important to tell them that you need to make the ear safe first, right? Okay, the surgical options that we have are mastectomy, which may be canal wall up or canal wall down, and tympanoplasty, that is grafting of the tympanic membrane and ossicular reconstruction. This may be primary or staged, that is done at a later date. Now, a few words about how to operate, whether it should be microscopic or endoscopic or combined. See, microscopes have been used for otologic surgery since last many decades, and they have provided sustained good results over the past few decades. But the advent of endoscopes and their use getting popularized in ear surgery has led many of the ear surgeons to shift over to endoscopic ear surgery. The scope of today's discussion is not to favor one or go speak against the other, but you must know that we have all these instruments or all these techniques, tools in our armamentarium. Okay, so it can be done microscopic, it can be done endoscopic, and the endoscopes can also be used as an adjunct to the microscope. Okay, I don't criticize any technique. Those who are doing it microscopic, they are very much in favor of that. Those who are doing endoscopic, they are very much in favor of that. But each technique has its own merits as well as demerits, which we are not going to discuss today unless you want to ask something specifically. Okay, now in the surgical options, we can do a canal wall up or a canal wall down surgery. The canal wall up options include a cortical or a combined approach tympanoplasty. The canal wall down options include athecotomy and modified radical mastectomy. Once you've done a modified radical mastectomy, you have more options, like you can leave an open cavity, you can do cavity obliteration, or you can do a soft wall reconstruction. A canal wall up cortical mastectomy means that the disease is exteriorized through the mastoid as well as the middle ear, and the posterior canal wall, which is the party wall between the external auditory canal and the mastoid air cell system, is retained. Now, when you're doing this surgery, the concomitant use of endoscopes, especially angled endoscopes, to visualize the hidden areas can really improve the disease clearance. Yes, we are going to discuss that, when to do canal wall up and when to do canal wall down. The most important thing when doing a canal wall up surgery is a proper patient selection. There are certain contraindications or straightaway cases where you will not be able to, or where you should not be doing a canal wall up surgery. Suppose there is a large canal wall defect which you will not be able to reconstruct. In those cases, you cannot do a canal wall up. If the patient is doubtful for following up, then you must not do a canal wall up, because the most important criteria or the most important single consideration for doing a canal wall up is that the patient should be ready to follow up with you. See, in our country, the health services are more or less concentrated to the bigger cities. And many a times, especially if you're working in Delhi and around, and in the government setup, patients will come to you from far away areas. You know, somebody is living 800 kilometers away, somebody is living 1,000 kilometers away, and they have come to the city, to the big city, especially for the surgery. They are staying with a relative, and they say, "Doctor Sahab, hum to 15 din ke liye aaye hain, aap hamara operation kar do." So if you tell such a patient that I will have to operate you twice, he will never come back to you. So in those cases, make sure that you do proper disease clearance, you do a canal wall down. Okay, and extensive disease involving the labyrinth, facial nerve, carotid, dura, sinus tympani, where you think the disease clearance might be compromised. If you retain the canal wall, please go in for a canal wall, canal wall up, please go in for a canal wall down surgery. Okay, so a re-exploration or a second look surgery is must when you do a canal wall up, and this has to be told to the patient. The patient has to be counseled for this before you operate. Is that clear? Does that answer your question? Somebody was asking me when to do canal wall up and canal wall down. These are definite contraindications for a canal wall up surgery. Okay. Okay. Then the other option we have for doing a canal wall up is a combined approach tympanoplasty. In this, again, the disease is exteriorized through the middle ear and the mastoid combined, and a posterior tympanotomy is done to visualize the hidden areas. Now, this technique is not very popular in India. It is popular in Europe, especially Germany, where they do this in almost all cases of cholesteatoma. But the important consideration here is that their patients are mostly ready for follow-up. So they can afford to do this. They do not use endoscopes rather than doing an angled endoscopy and then clearing out the cholesteatoma sac from the hidden areas. They do a posterior tympanotomy and do it through that. The only popular indication of posterior tympanotomy in India today is any answers? I expect all of you to answer this. The only popular indication of doing a posterior tympanotomy in India today. Yes. Very nice, Harjot. Cochlear implant. Yes, cochlear implant. Okay, now coming to the canal wall down options. The most common and the most popular surgery is a modified radical mastectomy. Now, modified radical mastectomy is a very versatile and very useful surgery because it helps in disease exteriorization very nicely. The external artery canal, middle ear, mastoid, and the entire mastoid air cell system. It is converted into a single cavity. The posterior canal wall is drilled down up till the level of the facial nerve. The important point here, which differentiates a modified radical from a radical, is that we make an attempt to preserve or reconstruct the hearing mechanism. See, earlier, a radical mastectomy was done to remove the disease, and there was no conscious attempt to reconstruct the hearing. But over the years, it was realized that if you are an otologist and you're not doing anything for the patient's hearing, then what have you achieved? So, whatever ossicular chain parts were available, they were either refashioned or they were augmented, and the hearing mechanism, an attempt was made to reconstruct it. Okay, so that is the essential difference between a modified radical and a radical mastectomy. And in today's date, hardly anybody is doing a radical mastectomy. There are very limited indications for doing a radical mastectomy. For cholesteatoma, only cases where it is extending deep into the petrous apex will you think of doing a radical. Otherwise, the standard treatment for cholesteatoma is modified radical. Okay, so this is the dural plate. This is the sinudural area. This is the posterior wall of the mastoid that has been drilled. And this is the facial ridge. This is the external artery canal. Anterior, posterior, superior, inferior. Is that clear, Harjot? So I have tried to place this picture in a similar orientation as to the diagram. Is that clear? Okay. Now, again, there are many ways to doing a modified radical mastectomy. The conventional method is going outside in when you start drilling at the McEwen's triangle and create a wide saucerized cavity from the beginning. The other approach is an inside out approach when you start drilling from inside and you try and follow the disease. Okay, whatever extent of the disease is, you drill only that much amount of the bone and you don't create an unnecessarily large cavity. Both techniques have their proponents and both give equally good results. Okay. Now, you want me to tell you what is the bridge and what is the anterior and posterior buttress, right? See, when you dissect the temporal bone and you delineate the posterior canal wall, you make it eggshell thin, you will realize that it is not straight. It goes like this. Okay. So the anterior part where the posterior canal wall fuses with the tegmen, that is the anterior buttress, and the posterior inferior part where the posterior canal wall fuses with the floor of the external auditory canal, that is the posterior buttress. See, actually it would be more anatomically appropriate to call it an anterior superior buttress and a posterior inferior buttress, because this is the way the canal is oriented. Okay, it's not like this anterior and posterior, it's anterior superior and posterior inferior. Okay, and bridge is the area which overlies the aditus. जो aditus का gap है, उसके lateral जो area, that is actually the facial bridge. Is that clear? Is that clear? The buttress and the bridge. Okay, now the essential part, that is the inside out. Okay, so in inside out, you don't start drilling from the McEwen's triangle. You start drilling from the attic region. You identify the disease and you keep enlarging your drilling area following the disease, and you drill only as much as is required for disease removal. You go just beyond the limits of the cholesteatoma sac and remove it. Unlike the outside in approach where you create a large saucerized cavity from the very beginning. Is that clear? Okay. Now, the essential thing that I want to discuss today is decision making. How do you decide whether to do a canal wall up or canal wall down? There are merits and demerits of both techniques. Canal wall up is more physiological because it gives you a near normal external auditory meatus, external auditory canal, and hearing. There are no cavity problems. Post-operatively, the hearing aids can be fitted easily, but the problem with canal wall up is that disease clearance may be compromised because you're not taking down the canal wall. There may be hidden areas where the disease you may leave behind, and there will be residual or recurrent problem. So a regular follow-up is a must, and a second look or a re-look surgery is required maybe 9 months to 1 year later. In a canal wall down, you make the ear less physiological. You give a wide external auditory meatus and canal, which may even be cosmetically problematic to the patient, especially in young girls. Then the patient may have persistent cavity problems like discharge, deafness, dizziness, dependence on suction, and difficulty with using the hearing. But the plus with canal wall down is that disease clearance is much better. So you have to take into account all these things when you decide what technique to follow. Okay, coming to hearing reconstruction. It may be done at the time of the primary surgery when you're removing the disease, or it may be staged to allow the middle ear to heal. there are two important components of this. One is the tympanic membrane repair and second is the ossicular chain repair. The materials that are used commonly for tympanic membrane repair are temporalis fascia, cartilage, perichondrium, and a composite cartilage perichondrium graft. All of these give good results. The most popular is temporalis fascia and then cartilage. When used properly and in the hands of experts, they give a very good graft uptake as well as up to the order of 92 to 95%, as well as very acceptable hearing results. For ossicular reconstruction, the commonly used materials are cartilage harvested either from the tragus or from the concha or even from the nasal septum, quite popular, and maybe refashioned ossicles. Although in cases of cholesteatoma, it is advised not to use the autologous ossicles incus because there might be a risk of micro deposits of cholesteatoma in the ossicles. Then we can use prosthesis, TORP and PORP made of various materials. Earlier, plastipore and hydroxylapatite were common. Nowadays, glass ionomer cement, gold, and most commonly titanium prostheses are used. The important thing to remember when you're using a prosthesis is you must place a slice of cartilage, split thickness cartilage, between this prosthesis and the tympanic membrane graft. Otherwise, there are very high chances of the prosthesis getting extruded through the tympanic membrane. Okay, so I would like to summarize. Unsafe CSOM is called unsafe because there are higher chances of complication. Whether you do a canal wall up or down, proper patient selection is the key. The treatment includes mastectomy and tympanoplasty. Cartilage is a very, very versatile and very, very useful substance for reconstruction of the tympanic membrane, ossicles, soft wall reconstruction, and to prevent extrusion of the prosthesis. Thank you very much. And if there are any questions, I think we have 2-3 minutes left. I'll be happy to take them.
Thank you very much, Dr. Ashutosh. Trainees, if you have any questions, you can just type or unmute and ask.
Yes, some people do use allogenic cartilage from other patients' nasal septum preserved in absolute alcohol for 3 weeks. It becomes it destroys the antigenicity of the cartilage. If you keep it in absolute alcohol for 3 weeks, then it can be used safely for ossicular reconstruction. Sorry, I missed the other questions. Can you please repeat? One or two people had put some questions. Okay, so soft wall repair is you can call it a combination of canal wall down surgery with benefits of canal wall up also. What you do is you take down the canal wall and remove the disease, because the main advantage of doing a canal wall down surgery is it gives you good disease clearance. So you take down the canal, but not so down as to go up to the facial nerve. You just remove it adequate to clear the disease, and then you reconstruct that defect with the help of cartilage. You use the soft tissue cartilage to reconstruct that drilled out posterior wall, and it gives you a near normal anatomy post-operatively. It gives you a near normal external auditory canal. So you eliminate the disadvantages of doing a canal wall down. Soft wall reconstruction is a okay. Mastoid cavity obliteration is when you use a soft tissue flap to fill up the mastoid cavity so that in the post-operative period, it has a very, very small canal size and cavity size, which is near normal, and it reduces the post-operative problems, the cavity problems that are faced by the patient. The 5 Ds that we discussed, those get eliminated. So these are all techniques to reduce the post-operative problems, cavity obliteration as well as the soft wall reconstruction. Okay, so if there are no further questions, I would like to thank you all, and especially Mr. Navneet and Nilima ma'am for this session. And I hope you guys enjoyed and got to learn something from this. Take care and all the best.
Thank you very much, Dr. Ashutosh Nangia, for the presentation, and thank you very much, trainees, for joining us.
Thank you so much.